So when we think of drug interactions specifically, the National Cancer Institute actually defines this as a change in the way a drug acts in the body when taken with certain other drugs, herbals, or foods, or when taken with certain medical conditions. So drug interactions may cause the drug to either be more or less effective or cause effects on the body that are not expected. So there are two big buckets that I usually think of this as. So you have pharmacokinetic and pharmacodynamic pathways.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Carissa Ganihong, Oncology and Bone Marrow Transplantation Clinical Pharmacist at Hackensack University Medical Center in New Jersey, about interaction pathways. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in our episode notes. As a reminder, this episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Welcome. Thanks so much for joining us today, Carissa.
Thank you so much for having me. I just do have to say that nothing that I say in this podcast is representation of Hackensack University Medical Center or Hackensack Meridian Health Network, and opinions are my own.
Wonderful. We are excited to hear those opinions. And to start this conversation off, let's start with just a general overview of what interaction pathways are and how do they work in the drugs that we give our patients.
So at the most fundamental level, interaction pathways are when you have maybe two or more substances that in some way end up affecting the other. So when we think of drug interactions specifically, the National Cancer Institute actually defines this as a change in the way a drug acts in the body when taken with certain other drugs, herbals, or foods, or when taken with certain medical conditions. So drug interactions may cause the drug to either be more or less effective or cause effects on the body that are not expected. So there are kind of two big buckets that I usually think of this as. So you have pharmacokinetic and pharmacodynamic pathways.
Great. So let's talk about those main differences between the pharmacokinetic and the pharmacodynamic interactions.
So when we talk about pharmacokinetics, what this is actually referring to is the body's ability to process the medication, whereas the pharmacodynamic interactions are referring to what the drug's effects are on the body. So kind of the reverse. The most common warning or flag we'll get in our electronic health record systems when we're kind of entering these different medications is we'll often get some kind of pharmacodynamic interaction that pops up. That happens when drugs have overlapping or competing side effects. So one common example, benzodiazepines and opioids, those will often flag as an interaction just because of the overlapping side effects of sedation.
And what are the four ADME or ADME components of pharmacokinetic interactions, and how do they work?
Pharmacokinetics, wherever you learn it, you often hear the infamous ADME, or this really stands for absorption, distribution, metabolism, and excretion. And that generally also represents the order, for the most part, in how a drug gets processed in the body. So first and foremost, you need to absorb the drug into your system, which is especially true for oral medications. So when someone takes an oral medication, it needs to be absorbed typically in the GI tract. The actual location within the GI tract of where it's absorbed will vary depending on the properties of the medication or the formulation of the oral medication. But this typically, after getting absorbed, will enter the hepatic portal vein. And so the first organ that these drugs end up seeing is the liver. The liver has really high concentrations of what we call CYP or cytochrome P450 enzymes. And those are just basically a huge family of enzymes that metabolize the majority of our medications, somewhere in the range of 70 to 90% of all our medications. And then the medications or substances that these enzymes, these P450 enzymes are acting on are often referred to as substrates. And so for the oral medications, because the liver is the first organ that the drug sees, when it's processed by these enzymes, we call this entire process the first pass metabolism. So absorption and this initial metabolic processes ultimately determine how bioavailable a drug is, which refers to how much drug is actually able to reach your systemic circulation or the target locations. So based on the properties of the drug and how large the drug is, whether it's lipophilic, whether it likes to bind to proteins, that kind of determines our next characteristic of distribution. So where does the drug actually go in the body? So this is typically measured in volume. Usually you'll see it written out as liters. So drugs that we say have very large volume distributions can go everywhere in the body to the different tissues, different organs. Whereas those that we say have small volume distribution tend to stay within the intravascular space or like within the circulation. And then the last process is really a pathway for the drug to get eliminated or excreted. Typically, they get eliminated in some kind of metabolized, altered form of itself, commonly through either urine or feces.
Thank you for that explanation. That's really helpful. Just thinking through the actual pathway of kind of what happens when after we take the drug or after we administer the drug for a patient. So that, I think it's very helpful to kind of break it up into those distinct kind of steps.
And we can also have drug interactions really in every part of this ADME process that can ultimately alter a patient's exposure to the drug.
Can you talk a little bit more about how drug-food interactions work and why they're important for us to be aware of?
So foods can not only impact absorption, but depending on the type of food, it can also impact the metabolism of the drugs. So one of the most notable food interactions that interacts with many different medications is actually grapefruit or grapefruit juice. This is known to be a very strong CYP3A4 inhibitor. So it's, again, one of our cytochrome enzymes that are very common. A lot of medications are metabolized through this CYP3A4 pathway. And so by inhibiting the effect of these enzymes, that can actually increase and significantly increase the concentrations of these therapies. It's not an interaction that's just limited to grapefruit. 'Cause I would say grapefruit being the food interaction is kind of one of the most well known, but it can also be seen with other foods as well, like pomegranate juice or a very specific type of orange called Seville oranges. And this is really just due to the presence of a substance called furanocoumarins. And then there's other types of food interactions as well, the ones I alluded to, the ones impacting absorption. There's several mechanisms for this. So one, for example, is that some drugs just need to be taken on an empty stomach or with food, or for other ones, it might not matter. Sometimes food increases the absorption of the therapy, which we don't want because it can actually increase toxicity. And other times it has the opposite effect, decreasing the concentration. And then sometimes the foods have vitamins or cations in them, like calcium, iron, zinc, and magnesium are common offenders where the drug likes to bind and chelate with these ions, and that can also prevent absorption. So overall, it's really just important to refer to lexicon or package insert of the drug or other tertiary drug resources to really know what's kind of the recommended administration instructions and how to manage it with food.
It's just very important to know that some of these drugs can have those drug food interactions that we just might not think about. Now, I have to chuckle because I'm 43 years old. I don't think I've ever had a drop of grapefruit juice in my life. So somebody must be drinking it, and I hope it's delicious. Maybe I'm missing out, but nevertheless, it's important to just be aware that whether we eat it or drink it ourselves or not, if there are interactions out there, having that awareness, being sure to inform our patients, provide that education is obviously very important to make sure that we can prevent those interactions if at all possible. Let's talk a little bit now about some of the anti-neoplastic medications that we give. Are there certain drugs or classes that are especially affected by these types of interactions?
Pretty much most anti-neoplastic medications will have at least one or some kinds of interactions. Pretty much all of the drug therapies are likely to have at least some identifiable pharmacodynamic drug interaction just due to the risk of potentially overlapping toxicities or conflicting effects. And then most of our traditional chemotherapeutic agents, those are typically metabolized through the liver, or very commonly are. And so those will often have both the pharmacokinetic and then the pharmacodynamic interactions to watch out for. Our kind of small molecule tyrosine kinase inhibitors or newer oral agents as well, those are also tend to be substrates of those CYP450 enzymes. And so those do often have many drug interactions to watch out for. On the flip side, we do have the class of drugs, the monoclonal antibodies, and these are very large, very complex molecules. These are typically administered IV. So their metabolic pathways are much different than kind of our traditional chemotherapies, these kind of simpler, smaller drugs. So they're not really processed by the same enzymes. Instead, they have alternative, kind of very complicated processes to break them down into various types of peptides. For those agents, the drug interactions then primarily end up being more pharmacodynamic in nature.
Can you describe maybe a little bit how these types of interactions might look different based on sort of the route of treatment that's being delivered? For example, if someone is receiving an oral agent versus a subcutaneously administered agent, how can that look different for patients?
So for our oral agents, we do kind of traditionally think that these have more chance of having drug interactions because, again, one, they have to first be absorbed. So that's the first step. And there could be potential for drug interactions just for the absorption. And then after being absorbed, then they go to the liver and undergo that first pass metabolism. So they have these extra two steps before even seeing the systemic circulation. Versus if someone is just on IV therapy, you're now directly infusing that drug into the circulation, which bypasses these two effects. So the interactions we're mostly concerned about, kind of thinking about the different ADME pathways, are really within the realm of more so metabolism and excretion. One kind of prominent example in oncology where dosage form really made a big difference is with an antifungal called posaconazole. So this is an azole antifungal that's commonly used for prophylaxis or treatment of fungal infections in oncology. Probably the area where people see it most is within the heme malignancy space. But when the oral formulation was first developed, it was only available as this oral suspension. And this suspension for adequate absorption had to be taken with a high fat meal. It required acid for absorption. And especially the high fat meal requirement, that can be really challenging in our patients who are receiving chemotherapy. They already have some kind of GI upset or mucositis. And then with the acidic environment requirement, well, a lot of these patients are feeling nauseous. Maybe they feel like they have some component of heartburn, and they're often also on agents like proton pump inhibitors, which can reduce acid and then reduce the ability for absorption. So it made it more challenging. You had to monitor levels to make sure people achieved either prophylactic or therapeutic ranges. So instead, on the flip side, if we just give it IV, we're completely bypassing these issues and we're not concerned about that drug interaction anymore. And now this formulation too can play a big role because they've also developed these delayed release tablets, which are kind of don't have the same issues as the oral suspension. And then for subcutaneous drugs specifically, you're still kind of bypassing that GI absorption requirement. Sometimes it just does take a little more time for distribution of drug through the tissues, but the drug interactions we're typically thinking about are associated with things like metabolism or excretion.
Let's talk now a little bit about the additive and competing effects in relation to the pharmacodynamic interactions that you've already talked about.
So, in oncology in general, when we're thinking about the optimal combinations of treatments, of course, we want to have good efficacy against whatever malignancy we're treating. But the ideal regimen also ideally wouldn't want any overlapping toxicities. So, if we hypothetically had some four drug regimen and every single one of those agents carried a significant risk of hepatotoxicity, probably be extremely concerned to give that combination of drugs. So this is also very true when we think of patients on multiple medications. So ideally, we don't really want too many additive effects because that's when we start to get concerned about toxicities. So thinking about one concerning potential for additive toxicities, an example I'll mention is with QTC prolongation. If someone, for example, is only taking one QTC prolonging medication, let's just say it's ondansetron or Zofran, which is a common anti-nausea medication we utilize in oncology, then we're probably not going to be super concerned about the need to monitor their QTC interval. We know that people with QTC prolongation are increased risk of life-threatening arrhythmias like torsades, but we probably wouldn't monitor this unless there's maybe other risk factors present. But when we start to add on two, three, four additional agents that can also cause QTC prolongation, then we do certainly become more concerned about that toxicity, and then we'll consider monitoring for those patients. And then on the flip side, we have our competing events. So the classical example that they often teach is that if you give someone a beta blocker that's non-selective for blood pressure, so an agent like carvedilol or labetalol, these target beta 1, beta 2 alpha receptors. Then simultaneously, they're on an inhaler for asthma. And the inhalers, they are beta 2 agonists, which would help bronchodilate and allow the patient to be able to breathe better. But then you're also on a beta blocker that could potentially antagonize those effects and make that inhaler less effective. So that's another very common example.
This is obviously very important in oncology because more often than not, patients at some point during the treatment that they're receiving likely are receiving more than one drug at a time. And so it just, I think, reinforces the importance of knowing not only the unique side effect profiles and potential interactions of individual drugs, but then obviously looking at those as a combination regimen, whether they're getting all drugs in the same day or it's in succession over a couple of weeks as part of a cycle, it just reinforces the importance of knowing all the drugs a patient is receiving as part of their overall treatment plan and being able to educate them appropriately on what to watch for or things to avoid. So now we've covered pharmacodynamic and pharmacokinetic interactions, but there's another pharma word that we haven't talked about yet, pharmacogenomic interactions. Can you talk a little bit about pharmacogenomic interactions with drugs and really how they work in oncology?
In general, with side effects of drugs, we kind of know that people are going to react differently from each other. Some people just seem like they get all the side effects, and others are perfectly fine. Other kind of person to person variability. Dosing of drugs too might be different in different countries or different ethnicities as a whole. They have been shown to have maybe different sensitivities to certain types of drugs requiring different dosing in different regions. And so humans are very genetically diverse. And so what the pharmacogenomic field is really exploring, examining, is they're really examining one of the pieces of the puzzle and understanding why people are responding so differently to our therapeutics. So their study is really the study of exploring how a patient's DNA or genetic makeup can affect their response to medications. So in that pharmacogenomics field, there have been a pretty large number of genes identified that are responsible for coding some of those common enzyme families that I had been discussing, some of those CYP450 enzymes, but other enzymes as well that are important for drug metabolism. Based on the type of gene, there could be some different categories where patients are normal metabolizers, intermediate metabolizers, or poor metabolizers, or there's some other categories as well based on the type of gene we're looking at. And that can ultimately impact the way you are able to metabolize drugs. Right now, too, for the most part, this is really still an evolving area in determining exactly how we can best utilize this information and then best incorporate it into a patient's treatment plan. Just to provide a notable example in oncology, or one that has really garnered a lot of attention lately, is the gene DPYD. This is a gene that encodes for DPD, which is dihydropyrimidine dehydrogenase, which is just an enzyme that is responsible for a key part of the catabolism or metabolism of fluoropyrimidines, which are one of our kind of a class of one of our chemotherapeutic agents of 5-FU or 5-fluorouracil or capecitabine. And so the genetic variants for this include being a DPYD normal metabolizer, intermediate metabolizer, or poor metabolizer. So if you're a poor metabolizer, so your enzymes are not functioning typical to a normal, so they're less functional than the normal metabolizers, of course, and then you can imagine you're going to be at much increased risk and of very severe, even potentially fatal toxicities from these chemotherapies. And so recently, the FDA, or somewhat recently, the FDA added a box warning for these agents to recommend DPYD testing prior to the initiation of therapy, unless there is some immediate treatment that is absolutely necessary. And there are just so many of these other potentially relevant genotypic variations. So another kind of common one that we always think about in oncology is G6PD, where if someone has G6PD deficiency, these patients can be at greater risk of hemolytic anemias when receiving certain types of therapy like dapsone or saspiricase are just a couple that have been associated with this risk. But overall, really is an emerging area. And there are some resources. There's the ClinPGX website that can help clinicians understand how genetic test results could potentially be used to optimize drug therapy.
It just goes to show how precision oncology, precision medicine are helping us to not only pick the treatments that evidence will show are more likely to be effective, but it also helps us to avoid the treatments or to potentially dose reduce or adjust the dosage of certain treatments that could be harmful if not used in the right way or adjusted. So just a great example, especially a relevant example for oncology and how we can use some of this genetic information and these biomarker tests to help guide treatment in a variety of ways. And so I really appreciate you bringing up that example. So are there certain useful resources that you would recommend that would help nurses to understand drug-drug interactions or where we can turn for support if we don't necessarily have a clinical pharmacist at the ready that we can call or collaborate with in our clinic environment?
The most helpful resource and something we definitely use from day to day are just our standard drug databases. So the ones that come to mind only because my institution utilizes them are resources like Lexicomp or Micromedics, but whatever your hospital has available, like they will typically have some kind of tertiary drug resource available to use where you can simply run a drug-drug interaction check. Sometimes there can be differences in what these resources are actually identifying as interactions, or maybe they might categorize them slightly differently on different severity levels. So I think that really is your most commonly used resource, super helpful, very reliable. Another good place to reference as well, especially for our newer therapies, is just directly on the package insert. They do highlight what interaction pathways we need to be concerned about might be for the drug. So a lot of them will list if they need dose adjustments. For example, they'll say, oh, for strong CYP3A4 inhibitors, this would require XYZ dose adjustment for that agent. But I do really believe those tertiary resources really are a great resource for your day-to-day activities.
Absolutely. And I think whether it's an electronic resource or, as you mentioned, the package insert, whether digital or actually from the package, just familiarizing yourself with where that information is located within those tools or resources, because sometimes half the battle is finding what you're looking for. And so the more time I think nurses spend looking at those resources, using them consistently, it helps them to be more familiar with the layout and kind of create a little bit of a shortcut to know, well, this is the section that lists that information so I can jump right to it. So those are some great recommendations. Thanks for sharing those. So, Carissa, how do you think healthcare professionals, nurses, pharmacists, and others, how can we help monitor for these types of interactions that we've talked about today for our patients? And what changes that we might need to watch for or maybe recommend in their treatment plans if we do see these interactions appear?
Our patients, especially oncology world, can truly be on so many medications. So we're always collaborating as a team to monitor for these interactions. Fortunately, I think right from the beginning, right from the prescriber end of things, as long as we have a good, accurate medication history from our patients, when we order these new medications, especially since a lot of places do use electronic health records nowadays, I feel like the first line of defense we typically have are those EHR electronic health record alerts that will automatically notify us of significant drug interactions. Also, too, thinking of where we're sending these medications for our patients to pick up, it's always beneficial when possible that patients just utilize one pharmacy so that pharmacy on their end also have the patient's medication list. One thing to note too is that although some drug interactions might flag, it may not always be clinically significant enough to actually change the dose. It may just be something we need to monitor side effects for. But nevertheless, the pharmacy that we're prescribing it to might not know the same clinical depth about what's going on with the patient as our prescribing ends do. And so they would often reach out just to confirm that it's okay for the patient to take the medication. I think on the nursing end too, just from kind of routinely seeing medications, you become very familiar with them. I feel like our nurses, because they're actually giving the medication, know so much offhand on specific timing that might be needed or spacing of administration, or if they're always questioning if there's any food interactions, how is the patient actually supposed to take this medication? Through education, they're really able to make sure that patients are taking their medications appropriately, or pharmacists too, nurses too, kind of being at the forefront of helping these patients understand how they're supposed to take their medication. It's always a team effort. And I think if you're ever unsure, you can always consult your local pharmacist, whether you have someone directly on your team or even asking if you don't have someone on your team, then you can always ask wherever you're prescribing the medication to. And so for pharmacists, I feel like drug interactions truly are one of the bread and butter things that we're always watching out for. So we're always here to help.
Outstanding. And, I think one perhaps unsung hero and critical sort of cog in the wheel of medication reconciliation are medical assistants that we partner with in the clinic environment, knowing so often patients ultimately they start somewhere in a clinic, and that's where we have initially report out and list out their medications. And so empowering all members of the team in that environment to just understand the importance of this. And of course, again, educating the patient of like, yes, it probably feels very annoying to have to repeat your medications every time or list every single thing. But I think our discussion today for me has highlighted just how important that is, and to not go through the motions and just kind of assume it's fine unless they say something has changed. I think it's really important for all of these reasons today that we discussed of just being very methodical about reviewing those medications and helping the patients to understand why we do it. Because ultimately we're trying to keep them safe and make sure that the medications they are taking or being prescribed can be as effective as possible and also not toxic if we can avoid that. So I think all of these things that we've talked about today really reinforce the importance of knowing what medications our patients are taking and herbal supplements, things, vitamins, things like that as well. And just making sure that we know how they're taking it and if the way they're taking it has changed. Well, Carissa, I really appreciate your time today. It's been a great conversation and I've learned a lot. And I think it's just been one of those things that we always kind of know is in the background of just watching for interactions. But I really appreciate the time you spent today talking through it in more depth. As we reach the end of our episode today, though, we like to always run through a series of some just quick questions to help summarize the things that we've talked about. So to start that off, how do you think healthcare professionals should evaluate any hidden or implicit bias they might carry just about the topic of interaction pathways?
I think that in medicine, or maybe I'm mostly speaking from the pharmacy profession side of things, that drug interaction screenings have become so routine for us to do, or we're constantly thinking about it. And it's really one of our most fundamental roles that sometimes I feel like we don't realize just how, or maybe not that we don't recognize that it's important, but maybe just don't fully appreciate how big of an impact, especially maybe some learners, they think that, oh, we're just doing drug interaction checks, but don't fully appreciate always the impact that this can have on our patients and their therapies. Because some drug interactions, when not caught, can cause very serious toxicities. So I just think we have to remember that these are all very impactful interventions. Another thing, too, sometimes there are situations where in some disease state, we have patients who are maybe always on combinations of therapies that are kind of always flagging as drug interactions. So on our end, maybe we're very familiar with it. But maybe on the other end of things, people who don't always kind of see these interactions every single day, they're not really as familiar with it. So they only have one piece of the puzzle. So overall, I feel like collaboration is always important, reaching out to providers' offices for clarification, or maybe even putting notes in the prescriptions can be helpful to the pharmacy, just kind of working together to really provide care for the patient.
What are some common misconceptions that you think are out there about interaction pathways?
One of the big concerns is always polypharmacy. Like I mentioned before, our patients are truly can be on a lot of medications in the field that I work in transplant. Patients automatically from their transplant are on many, many different medications that can potentially predispose them to side effects. And we're always trying to simplify therapy when we can. But I think when it comes to the many drug interactions that may flag in these situations, we really have to kind of look at the patient as a whole. Like, how long have these patients been on these therapies? Are they having side effects? Have they been on the combination for a very long time now? So I think that not just looking at the drug reference and kind of seeing that there are like 10 different interactions flagged, but really assessing your patient as a whole can be very important. Just because real world practice, of course, is not black and white, it's often very gray. So it's just too important to use clinical judgment in those scenarios.
What's something about this topic that's not often discussed, but you wish people knew more about?
Whatever drug reference that you use when you're kind of doing your drug interaction checks, they'll typically provide some kind of categories. And I'm just only using Lexicomp as example because that's the reference I'm most familiar with. But it'll break it down the severity of the drug interaction to like A, being no and known interactions, B, being known action needed, but there's a possible interaction, C, monitoring therapy, D, considering therapy modifications, and then X being contraindicated. But beyond just listing out the categories, if you do click into the actual interaction, it does provide a lot of information in the summary or discussion section of what the interaction actually is, what actually happens to the concentration of the drug in the body. Is this a theoretical interaction, or did they actually do some kind of PK studies to evaluate it? So I always find that these sections are very, very helpful to review and make clinical decisions. Like reading the actual description may kind of change your mind about what you want to do for the patient.
And what additional training or education do oncology nurses need to stay current on this topic?
I would say it's really not possible to know and memorize every single drug interaction out there, especially with all our new therapies coming out, which is why we have all these really great resources. So I think that over time and with practice, you kind of make associations about what classes of drugs or kind of what are the common big offender in terms of drugs that always seem to have drug interactions. But again, you always have those resources that you can refer back to really just double check yourself and check for those interactions.
And finally, are there any additional resources for patients or other healthcare professionals who might want to learn more?
So I've already kind of mentioned for pharmacogenomics, you have that Clin PGX website. And then for day-to-day practice and using kind of whatever your institution has as your drug database. And then for more information on pharmacokinetics and pharmacodynamics, I can provide some articles for you in the show notes.
We'll be sure to include those in the episode notes for our listeners to browse it later. So, well, Carissa, thank you so much for joining us again today and talking through what I think was very interesting, talking about these interaction pathways. And I really appreciate the time that you've spent sharing your expertise. Do you have any final comments to share with our listeners today?
I'll just say that there are times when drug interactions are super straightforward to manage, and other times where they're extremely complicated and challenging and requiring big deep dives into the literature to figure out how to manage them. But fortunately, we do have so many resources available. And again, that this really is the bread and butter of pharmacy. So you can always consult your local pharmacist for help.
Wonderful. Well, thank you again.
Thank you so much for having me.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.